True. Um, yes. Welcome, all the participants of today's webinar. Today's topic is Challenges in Implementation and Sustainability of Healthcare Using ICT. I would first like to express my gratitude to SPIDER for making this webinar happen. And the objective of today's webinar is essentially to digital health experiences between Asian countries and African countries. In Bangladesh, the government has been scaling digital health very rapidly and in a very major and significant way. And we are very honored that some of the primary leaders of the digital health revolution in Bangladesh are present here today. And similarly, we also have some digital health leaders from several African countries who will be sharing their views. Before we begin, I would like to briefly introduce our chair and our guest speakers today. So to begin with, I am Ridul Chaudhary. I'm the CEO of mPower Social Enterprises, and I will be helping moderate today's session. Professor Anuraj Shankar will be the keynote speaker for today, and he's a leading global researcher and practitioner in digital health. His current focus of work is in Indonesia, and he's a research fellow from University of Oxford. He's currently leading several global mHealth solution deployments for community health workers to digitize their work processes and implement different kind of decision support systems for them. To my right is Dr. SM Mustafizur Rahman. He's the line director of National Nutrition Service, Director General of Health Service, Ministry of Health and Planning and Family Welfare, Bangladesh. Under his leadership, NNS has deployed national level ICT solutions for nutritional field activity, monitoring and decision support. Dr. Mustafizur Rahman will be chairing our session today, and I'm very grateful that he could make time from his busy schedule to be present here with us today. We also have Mr. Islam Bulbul, a Deputy Program Manager from Nutrition Service. He's closely working with DDHS, MIS, and NNS to implement national level health informatics solution and policy level data management activities. We also have here with us Engineer Nazmul Ahsan. He is currently serving as the Deputy Program Manager at the NNS, Institute of Public Health Nutrition, and he leads and manages the MIS system for nutrition services. And soon we will be having, joining with us, Mr. Muhammad Abdul Hannan Khan. He is essentially in charge of the entire DHIS2, essentially the government data server, which administers all district level data and then field level data from the field. We are also with us several African speakers from Africa. First, we have Mr. Johnblack Kabukye. Forgive me if I'm pronouncing it incorrectly. From Uganda, who is a health informatics expert for Ministry of Health Uganda. And he's leading many projects to involve community health workers using ICT for timely and quality health service delivery. We also have with us Claudia Nizigiamana, and she's the Vice President of the Advisory Board of National Network of Young People Living with HIV and working with ICT interventions to improve HIV service delivery. We also have with us Dr. Norberto Banze from Mozambique, and he's currently working at REPSSI to increase access to services for beneficiaries using ICT. So I would like to hand over to our chair, Dr. Mustafizur Rahman, to formally start the session.
Thank you. Assalamu alaikum. Good afternoon, good morning, good evening, whatever it may be applicable, any part of the world. So this is very important because what we are doing, that is, we are just transforming from one area to another area. Bangladesh health system, nutrition system, it was monitored under the DGHS and Institute of Public Health Nutrition in a analog system, in my paper-based system. In 2011, we have just started digital system, and from there, by this time, our district health information system, which is known as the health shape. And in DGS as a plan of current sector-wide approach underneath of the health, nutrition is one of the components. And nutrition is just ensuring two indicators, what we call the disbursement link indicator of the IDA fund, which is led by the World Bank. One is the maternal, another is the child-related. We are ensuring all these things through ICT, and at the beginning it was nowhere. Now we can say it is in a good shape. In other way, when you usually go every 6 months for nutritional vitamin A campaign, that usually we do the real-time monitoring. We also do other things in the ICT, and we are planning to do many other things. Challenge implementation ICT is not that much easy because our employee or the officials, I don't know whether I'm in the connection or not. So officials, they started their career in the paper-based reporting, then they started the online-based reporting. So there was a problem at the beginning. Now the problem is reducing and our report is becoming better. Sometimes capacity of our digital system is limited, and sometimes there are problems both in the human being and both in the our digital system. It doesn't matter. We are trying to do all the reporting in digital system ICT management of health program. Especially I'll talk about the nutrition program, and for this we are getting support from all the relevant stakeholders. It is other ministries, it is DPs, it is UN, it is development partners, World Bank, and others. They are taking care of us, and then at this moment I'm a bit confident that we are doing something better than the earlier, and I'm hopeful in future we'll do something more. Thank you. Over from my side for the timing.
Oh, okay. Thank you so much, Dr. Mustafizur. Now we can possibly move over to the keynote speaker, Dr. Anuraj Shankar, to deliver his keynote speech. Thank you so much for sharing.
Yeah, can you hear me okay? Okay, I cannot hear you, but if you can hear me, just give me a thumbs up. Okay, great. All right, let me go ahead and start then. I'm just going to share my screen here. First, thank you so much. It's great to be here with you all on this event. And I don't know why, for some reason, I can't. But I'll go ahead and start. If you have a comment or something to share, put it into the chat box, and I'll keep a look on that. So I'm going to enable my screen sharing here. Let's see. Start screen. Okay, just give me a second here. Okay. Just a second. I'm having some trouble with this screen sharing. It's not going. Try it again here. Enable screen sharing. Okay, there we go. Okay. Great. So you're able to see my screen there, I assume? Let me go ahead and. Okay, great. Excellent. So just a quick review here. I wanted to give an overview of strategies for overcoming challenges of implementation digital health at scale. So just want to share a few experiences and really highlight on some things that might be a bit unconventional, in this space here. So the commonly we think about scaling up and what is scaling up. So it's essentially a deliberate effort to increase the impact of innovations for the benefit, of course, of more people. And it may depend on the capacity to adapt, right, to continue to improve. And this is highlighted very well in a MAPS toolkit for mHealth assessment and planning from WHO in 2015. It's a very nice resource to look at if you get a chance. So some of the common pitfalls that we experience, and some of these are highlighted in the toolkit, is as you have a digital solution and you think about scaling that up, let's say you've deployed in a single community and you want to scale it up to many different communities or the whole district or province, often people think, well, I'm just going to replicate the same type of process on a larger scale. And of course, that doesn't always work because as you scale up, newer types of problems emerge related to scale. And just like when you link multiple systems together, you get some emergent property that is good. Likewise, when you scale up and you have multiple systems working together, new types of problems emerge. A similar idea around that is assuming this one-size-fits-all idea, and also assuming that whatever you designed this year is going to work next year, or what you designed today is going to work tomorrow. So it's not just one size fits all for problem of that thinking for different locations, but also for the same location, because that need may change over time. This is the other assumption when it comes to the costing, that often people will think that, as you scale up, the cost is not going to change per person, or they assume it's going to be reduced per person. That could happen, but it's also possible costs could actually go up. So if you're having a digital solution and your goal is to reach as many people as possible, really watching carefully how you scale that up makes a really big difference. So I want to highlight this access and domains of scaling again from the MAPS toolkit. And this is a nice review of different steps really going through to scale up your mHealth intervention, from groundwork to partnerships, financial health, technology and architecture. Often we focus the most on this, the technology and architecture part, but this part number 5, this axis number 5 of operations, particularly the personnel and training and support, is very important, and likewise the monitoring and observation. So in that context, I just wanted to walk you through very quickly how we got here in this sort of evolution of mHealth or digital health solutions. We started many years ago, probably more than 25 or 30 years ago, with sort of first generation digital health solutions. Essentially, these are one-way information flows, like we used to do, essentially having information collected on a tool, a digital tool, maybe for a survey. We eventually went to more smart processing, which was this idea that having a two-way information flow, this is second generation. And third generation work really related to having action related to the information beyond the main point of contact, of collection of that information. And you see here fourth and fifth generation systems that are just now starting to come online, where you're able to reach at scale many different people, but particularly you're creating action across several different types of field workers. So let me just check here. Okay, I'm sorry, I de-shared there for a second. This brings me to this idea, this really this fourth/fifth generation system, Open Smart Register platform. If you haven't heard of this, you can go to smartregister.org to get a better idea of this. This is a system that actually Amrita and team at mPower were co-founders of this and have done amazing work with it. Likewise, our team here in Indonesia at the Summit Institute of Development, Ona Systems, who is the one of the core developers of this Open SRP, and IRD as well in Pakistan has really played a very important role in this, and of course the World Health Organization. And you can go to smartregister.org and get an idea about that. But essentially, Open Smart Register platform is a digital tool for frontline workers to take their paper registers, port them onto the system, and provides a lot of management of the tasks, service reminders, and so forth. Here's just a look at some different screenshots. So we did an adaptation of this in Indonesia for skilled birth attendants, and went through several processes of prototyping, specific coaching sessions, pulling information out of that, and getting feedback back and forth about what sort of app should be designed, how it should perform, and so forth. So this is really what a lot of groups, I think, go through, the beginning of designing something well that leads to scaling, as an example of a screenshot. And in this, we were able to create, of course, the dashboards that a lot of you have created, and enabling supervisors and senior officers to see what's going on, information that is, being fed through the frontline health workers using these kind of tools. We even went through and created these sorts of scores for each of the workers: a head score, hand score, and heart score. The head score was, of course, what the person was aware of on their job task. If they were a skilled birth attendant, were they aware of how to deliver a baby properly, or the importance of anemia in pregnancy. And their hand score was how well they were doing their visits on time. This is presumably something that having a tool, a service delivery enhancement tool like OpenSRP, or a lot of the apps, how it can make a big impact for them. And the heart score was how well they were able to be responsive to the demands for care by their clients, particularly the high-risk clients. So we did this deployment, created these indicators, and this is just an example of head, heart, hand scores for 13 of these skilled birth attendants. And you can see the max you can score on any of them is actually a 1 or 100%. But a lot of these scores are, the head scores are the highest, maybe not really as good as one would hope, but you can see the hand and heart scores are particularly on the low side. So, of course, the goal of digital systems is to be able to collect this information on performance, feed this information back to frontline workers, and go through coaching exercises where they can, in fact, improve. So we had, in fact, done that quite often. We found some improvement, but ultimately, that step alone was not really enough to lead to higher impacts at scale. So these cases became important as the actual use case of what data is being collected, for what reason. That data has to be, in fact, geared not just toward client care, but specifically geared toward evaluation of the frontline health worker. And this underlying assumption many of us have had, that digital tools themselves can prevent bad data. That is not true, certainly not true at scale. It's one tool that can be useful. And I want to highlight really this point number 4, the human gap, which I think is probably the most important gap related to scaling up digital health solutions. So it's not the technology gap, it's the human gap, which is supervisors of frontline workers maybe don't understand whatever analyses are being presented. Maybe workers don't trust the analysis or the conclusion. And very often supervisors won't take action because in the framework that they're working in, they're not able to actually do things that lead to serious improvement in worker performance. So the gap ends up being having the data actively used at scale to actually improve care delivery. And that gap is not a technical gap, it's actually a human resource gap. So I put this quote really at the end, it's really humans help humans, and the technology is simply a tool. So that's something to keep in mind. So with that idea, what we decided to do with the Open SRP deployments in Indonesia was decide that we would in fact link these humans together more effectively. And in this case, linking these multiple frontline workers together. So the skilled birth attendant, vaccinators, early childhood development workers, and nutrition workers. So the idea that these individuals, in fact, as a unit of humans working together, would more effectively be able to create reinforcement for each other at scale, and therefore deliver more effective implementation at scale. Some of the advantages to them, remember, we're rethinking this about really what are the advantages that we can provide for them. So this is one of the advantages, is that there's so much shared indicators that these workers have to collect. If they work together and their data are shared between them, as you can see here, there's multiple workers, different types of data are jointly collected. If one person collects that piece of data, it gets shared across to the other, so that other worker doesn't have to collect that same data again. So as I highlighted, up to 40% of all the information collected across these multiple frontline workers is actually shared or redundant information. And so doing this provides them incentive to actually help each other. So you end up in a situation where there's a advantage of this for the individual worker and for each client, because the shared record for each client ends up being populated by multiple frontline workers. So here you see expected data and what they actually collect, and then the compiled shared data when you're sharing data across nutritionists, vaccinators, and early childhood development specialists. So let me pause there and see if there's any questions coming up at this point. Okay, I'm just going to go ahead and continue then. So what we observed from this is you can create this kind of continuum of care at scale. So if a woman is pregnant, community health worker might detect her. This data sharing enables other community health workers to know that she's pregnant and getting care. When she shows up to the skilled birth attendant, this worker and the nutritionist already have information about her. She delivers a child. That child health record is automatically created, and other frontline workers are able to, in fact, provide the care that is required. So you end up creating a coordinated network of frontline workers so that, in fact, each client is cared for by this team of workers. And interestingly enough, when we deploy this at district level, what we're able to see over time when we compare intervention to a control group is that we do see improvements in antenatal care coverage, but the big change that we're seeing when these workers work together is this postnatal care, which was not being provided before, is actually being provided now. Now, of course, the levels could be much higher, but what's interesting about this is a emergent property of these workers being networked together at scale, and actually being able to create reduction in the mortality rate in the population. So again, this is a emergent property at scale of multiple frontline workers coordinating with each other and helping each other to succeed, and also being aware, like if I'm a frontline worker, I know now that other frontline workers are aware of the work quality that I'm doing. So it's not just driven by the supervisors, but it's driven by workers themselves being connected as human beings, being aware of the work they're doing. So the insights for scaling on this, essentially, a good app is essential, but a good app is not sufficient for scaling. One-time app development is also not enough. You have to continue to develop that technology over time as an ongoing type of process. Number three, the human resource integration with action for improvement is absolutely critical. You must have a big investment to get successful scaling in the human resource aspect of it. And then this other thing I didn't discuss much, but linking the use of digital tools with financial incentives. In a lot of countries now, national health insurance schemes are being deployed and being able to link actually use of digital tools directly with the processing of insurance payments or payments directly to frontline health workers is a huge incentive now available for scaling. And you can't neglect actually this fifth bullet point around, as a digital tool or an mHealth deployment organization, whether in government or elsewhere, really working with local officials to create laws and financial support to maintain digital networks for scaling. That's absolutely critical. That can't expect these kind of things to be ongoing funded through international funds or NGOs, but in fact local laws specifically for financial allocations need to be created to get scale. And last one, I showed you an example of this, leveraging synergies across the system at multiple levels of the system. Single deployments, interestingly enough, may not be as effective as more complex deployments because you're able to create a system. So creating a system, enabling that to adapt and expand at scale is probably going to be more effective in the long run than just a simple single frontline health worker deployment. So it really focuses on this. Alone we can do so little, but together we can do so much. So thank you. I'm going to end my presentation there. Going to stop sharing. So thank you. I hope that was clear. I hope my connection held up throughout that. For discussion.
Thank you so much, Dr. Anuraj, for that very inspiring presentation about your experience in Indonesia, and also focusing on the facts that that operations and monitoring are very key aspects of digital health, which are often ignored. I mean, when we're designing digital health solutions, I mean, how it changes work processes, how it redefines what a manager is able to do, what a field worker is able to do, how it redefines the relationships between different layers of managers and subordinates are things that are often not designed in advance, that become very, very critical bottlenecks when actual implementation, I mean, during the actual implementation of digital health. So Dr. Anuraj, thank you so much for your insights on some of those points. Right now, I would possibly hand over to Dr. Bulbul to make some of his remarks.
Thank you very much. I just say you good afternoon from here. This is really an interesting subject that to talk on the challenges and its implementation and sustainability of the healthcare using ICT. As part of nutrition, as I work with the nutrition part, so I will talk mostly over that issues. You know that the National Nutrition Services is a 5-year plan, and the Ministry of Health and Family Welfare has designed this 5-year plan. And we actually conducting the life cycle approach to provide the nutritional services to our population from, I mean, birth till death. So this is almost the under 5 children for the maternal, adolescent, and elderly populations. So actually, we are using ICT in 2 ways. One is for providing the service, and another way is for monitoring the service. So for, I mean, providing the service, actually, we are trying to use mobile phones, as well as, I mean, making some electronic services like e-toolkit and other services for the population as well as for the frontline workers. So from the National Nutrition Services, we have planned for a 5 years milestone, and we are actually using a lot of technologies. Especially, I want to mention that you have already heard the name of District Health Information System. So we are trying to collaborate, closely collaborative activities with Management Information System of Director General of Health Services. And we are using the platform of District Health Information System, usually the maternal and child health part. I'm trying to articulate some points, especially our strength. Since 2009, we have started to using mostly digital health platform, and nowadays Bangladesh is one of the example. Especially, we are using from the nutrition OP. That is, we are using as a part of already you have heard, that is disbursement linked indicators. That is the part of our disbursement of our money here in our OP. So we are trying mostly using the maternal and child health issues. So there we try to capture data through the district health information system, and also it's automatically provides the dashboard and all other analysis, so that the managers can take decisions from the central level, as well as the worker can also see how their progress they have made. So this is actually doing great. Finally, for the monitoring purpose, we are also using the platform. It is called ONA software for field level activities. So in the ONA, when a person goes with his device and his mobile phone, he can actually collect the data, and when he put the informations into the mobile phone, it automatically also collects his geolocation. So this actually helps us, whether the managers or the monitoring people really go to the fields or not. Secondly, what is the situation of the field, so we can easily take the decisions in a good manner. Finally, I will not take so much time. We know that our time is limited, but currently the platform we are using here for the nutrition services as well as for the monitoring is wonderful, and I think it is one of the best example overall the globe, and we will work in a coordination manner, and in a sustainable way, so that we can move forward for improving nutrition, so that we can easily achieve the goal of SDGs. Thank you very much.
Thank you, Dr. Bulbul, for that nice presentation. So should we go to the African speakers now? If Miss Claudia is here, maybe we could go over to her. Miss Claudia.
Hello. I'm here now.
Yes. If you could.
Hello.
We are not able to see you. You're not able to see. While Miss Claudia is getting back online, can we move over to Dr. John Black? Dr. John Black,
yes. Are you here? Yes. If you can unmute yourself on that side, and maybe just give me a thumbs up if you can hear me. Great. So it's afternoon here. Good afternoon, everyone, and evening or morning, wherever everyone is listening in from. Thanks, Anuraj, for the introduction, for the keynote. I had a question that I posted somewhere there. I hope you get a chance to give a comment on that. But I'll give a few comments or remarks concerning the topic. So as I was introduced, I'm John Black. I work at the Uganda Cancer Institute, which is in Kampala, Uganda. And I'm a medical officer there. So I do clinical care, but I'm also a health informatician. So I do digital health solutions there. Now, the Uganda Cancer Institute, to give you a bit of a background and why I do the health informatics or digital health work that I do, is that the Uganda Cancer Institute is the only cancer management or cancer treatment center in Uganda. And for a long time, it was only one site. Uganda is 40 million people, and having one hospital that provides cancer care in one location means a lot of challenges for people to access cancer services. That is also made even more crucial because cancer is one of the leading causes of mortality and morbidity. Normally, when we discuss issues or challenges of healthcare in developing countries, we think about infectious diseases. We think about HIV and TB and malaria, and this is also where a lot of funding goes. And you can also see this in terms of digital health priorities. So if you looked at how many projects that are doing digital health in relation to cancer care and how many are doing HIV, for instance, or how many are doing ICT solutions for TB, malaria, you find that there's a really disproportionate number going favoring the infectious diseases or the what you would call traditional public health challenges. So as the example you've just presented about nutrition and maternal and child health, and very few people are dealing with non-communicable diseases, cancer, diabetes, hypertension, and yet now these are becoming increasingly more important public health issues. So the project that I'm working on right now with the support of SPIDER is a cervical cancer screening project using telehealth. And again, cervical cancer is the #1 cancer in Uganda. Even though it affects only women, it actually is the #1 cancer when you combine both men and women in Uganda. So that's quite big. The other problem is that cervical cancer cases that we get come in late stage. So you get stage 3 and stage 4, 90% of the cases. And this is a problem because cervical cancer is a cancer that you can screen. Cervical cancer gives you up to 10 years for you to detect it before it becomes cancer. It takes time for the changes to go from pre-malignant lesions to actually cancer. So you have a window of 10 years to be able to catch this case, but we still get 90% of our cases in stage 3 and stage 4. So then we think, how can we make the healthcare system more able to deal with the cervical cancer issue? And so that's when we decided to use digital health solutions, because there's been evidence that digital health solutions have an impact. So what we're doing right now, we provide cervical cancer screening services in the remote sites of Uganda, where this, like I mentioned, Uganda Cancer Institute is only in Kampala, in the capital, which means that many people do have to come to to the capital city to get cervical cancer screening and treatment. And if you have 40 million people, you cannot deal with all of them. So you need to train more people at the remote facilities at the front line. And also what we're doing in this project is to actually provide them with the possibility to do a teleconsultation. So we are using mobile phones. We are using Gynocula, which is a portable mobile colposcope, which allows us to capture the images of the cervix and transmit these over the mobile broadband in a mobile app. We're actually using ODK. So someone already mentioned about using open source solutions. We use these to transmit them to the frontline, rather to the cervical, to the Uganda Cancer Institute, where we have gynecologists that can give feedback. We also, of course, capture some patient information that is important in making a conclusion. So that is a brief of the project that I'm working on. There's a few others that we're dealing with, but I wanted to make comments about the experience in regards to issues of sustainability and scaling up. So the things that I'm going to mention are not very unique to what Anuraj mentioned. And one of them that I think is very crucial is the idea of designing with and for the users and understanding the context. Because coming in from a clinical background, I know that it is very hard to move things in healthcare, especially getting doctors to adapt to technology is very challenging. And the reasons are many. Doctors are, the healthcare environment is a very risky environment. You cannot just experiment with things. You cannot just come and say, okay, this thing, let's try it and see. There's a lot of, the stakes are high. If things go wrong, it is people's lives that are going to be lost. So it is important. So healthcare providers are very guarded when it comes to innovations, when it comes to technology. You need to first get evidence to show that this is a solution that is not going to cause problems, number one, but also two, that it is going to actually improve. So first, do no harm, and then be able to provide some benefit. So this is an important thing that sometimes is skipped because people come from elsewhere, from developed world, and they come with solutions and say, well, this thing has worked here, let's use it here. But if you don't understand the context where you're going to implement, if it doesn't fit within the workflow, if it doesn't fit even within the pressure points, the issues that people are facing. So if you come in and say, well, this thing is going to solve issues of data collection. But if data collection is not the problem that the users are having, then they're not going to take it up. So you have to understand what is the issue that the users are facing and then design your solution to that. So it is very important to involve users, the end users. As I mentioned, clinicians tend to be very guarded when it comes to technology, and that is because they are trying to avoid harming the patient, but they also have limited time to experiment on things. So if it is going to cost them extra time, without giving them so much in return, they're not going to use that. So that is one of the issues concerning sustainability and scaling up. First, you have to get people on board. The second thing that I wanted to talk about is I think it was in axis 6 of what you mentioned about monitoring and feedback. So I think this is also something that often is ignored, but I think it is important to give the users, but also managers and administrators and ministries of health, to give them to monitor the projects, to monitor the implementation, and the monitoring and the feedback should be tailored to things that they can actually act upon, and things that communicate to them. So I'll give an example. Many times you have projects. Let's say if you implement like DHIS2, for instance, or any HMI solutions, and you have outcomes that are more on a national level, these outcomes are good for the Ministry of Health, but the user who has the patient, who has to enter data, if this outcome is very far from them, if it's not something that improves their time, for instance, if it's not something that makes the patient that they are seeing to improve in the care that they are providing to them, it might feel very distant that when you say we're having this number of people getting HIV treatment in the whole country, that seems to be very distant compared to if you told me that your patients, you as the clinician in the clinic, your patients, 20 of them are missing their HIV treatment. That is an indicator that is sort of close, is personal. So we need to have these outcomes when we're doing our monitoring and feedback. We need to have these indicators that make sense and personal to the end user, and then we can aggregate these to give the national level indicators. So that's the other thing about audit and feedback and monitoring, and how to make it that it is appropriate for the end user who is implementing the system. The other thing that I think that have been mentioned that we have to look into is the issue of human resource, and the human resource comes in two forms. There's human resource from the healthcare side, whereby if the system is if there's competition for time, if you're going to provide care to patients and also spend half of that time fidgeting with the system, entering data into a system or entering data twice or something, that competition for time and taking away patient quality patient care can affect acceptance and implementation of systems, and that has to be looked into when you're designing and making sure that the system fits into the workflow, making sure that it doesn't get in the way of patient care, because that is the priority that clinicians have. The other issue is with human resource is the technical side of human resource, having people who are available and they can respond to issues when systems fail, and they can be innovative, sort of understanding what the clinicians use and improve the services and the functionalities of systems. Now, I'm giving these in general, but I've seen them from my experience, but I've also heard from other projects that have been ongoing. So there's a lot of other issues, of course. Policy issues have been talked about. These are important, but I'm speaking here from the side of a clinician and my experience in getting digital health solutions in place. I'll pause here and allow questions, and maybe the other contributor to get online. Thank you.
Maybe we can save the questions for till after the next presentation. Is Miss Claudia back online? Or is Dr. Norberto, are you online? We're not able to see you. Oh, I see. Okay. I see. We just found out that the net may not be that steady due to the elections going on in Mozambique. We know that all too well, coming from developing countries. But are you able to speak? I mean, without turning your video on? So far. Maybe one of the questions that is posed to Dr. Anuraj is regarding the cost effectiveness of different digital health projects and how take to kind of, because this is often one of the big questions that government stakeholders have, that is this really cost effective in the long run? So how do you kind of tackle that kind of a question? Any insights on that? And I'll pose the same question to Dr. Mustafiz after Anuraj has a...
Yeah, that's an excellent question. So what we do actually is we go through the analysis and we look at the improvement in care quality and coverage of care, and provide an estimate around worker efficiency and what they're actually achieving, cost per health delivery.
Hello?
Yeah, so basically looking at the cost per health delivery action item and
Hello?
showing how this is being self-effective, or being how this is. Oops, are you able to hear me? Okay, yeah. So it's those sorts of things. I think really asking them, you know, what are the things that are important to them to know that this deployment of these digital tools is actually effective and cost effective. I think that
Hello?
the problems that occur often is that if the system isn't working or has a lot of glitches in it, there's a lot of complaints. And so you have to get to a point where it's at least smooth enough so workers don't have to struggle with the app, or if their connectivity isn't good. So I think if you can get to that point, then being able to look at the data very carefully and show, look, here's the efficiencies that we're gaining is very good. And just in general, the cost of, you know, providing a tablet, being able to track your clients, making sure that service delivery is on time, is certainly much cheaper than a paper-based system. But keep in mind, a poorly used paper-based system is much cheaper than a poorly based digital health system, or a poorly used digital health system. So if you're going to invest in a digital health, make sure that, you know, you're doing the investment to make sure it's getting used. Otherwise, you know, it's not cost effective. If it's not used, it's not cost effective. Yeah.
So in terms of cost effectiveness of digital health, I mean, how do you kind of see it from your perspective, particularly from the perspective of NNS? Why have you decided to adopt digital health, and then what gains are you getting out of it from a policymaking perspective?
Thank you. Basically, in NNS, we have found if we can do it easily, it depends on three parties. One party is the server, how much capacity it can take. Facilities, it can work during online or offline. If it is online, when there is no net, it will not work. So offline option should be there. If we think about the device, if it is iPhone is not taking the owner. So we have to go for any get tired and he or she will stop. So these are the challenge. Even we usually some SMS. What we did last week, we have sent SMS to all the root level worker of 15 districts. At the beginning last month, we get only 5 to 7%. 5 to 7%, yeah, 5 to 7% answer of those SMS. After a very good guideline and frequent letter explaining all these things and involving the district level manager and the division level manager and the sub-district level manager, second time we got response more than 50%. And if we try, and we have even solved some of their problem about their logistics, about their supplies and others, it has created some positive impact. Okay, if we send all these things, we can get the confidence they have already got. So I think now it depends on the motivation level. It depends on the motivation of the man behind the mission. So I think from NNS point of view, still now we are getting positive because we have a team here which is absolutely working for this issue. We usually call nutrition, information, and planning unit. So they are really giving their hard labor and their intelligence to get the result in this area. And about the motivation, we can go for some result-based incentive. It will help a lot because even in the weekly we have a video conference with all district manager and the sub-district manager as well as the tertiary hospital manager throughout the country. We usually give some result. Okay, your unit is the best unit this month. Your unit is doing good, but there's a scope to get more better result. And some are not doing really good. Then we usually ask them, okay, what is the problem? How to overcome all these things. So sometimes you'll give some reward, sometimes you will give some incentive, sometimes you need to clarify the total activities so that other side is equally sound. And I think this is my experience so far. I'm facing problem every day. I'm facing problem in every event, and I like to come up with a solution. So I sometimes not only listen problem from them, I usually ask them, in your opinion, how we can solve it. So I usually take suggestion from the laws, and my team is doing better now. I hope it will be better day by day. Over the time, I think DHS2 uh, nutrition through the DHS2 would be in very good shape. Thank you.
Thank you so much, Dr. Mustafizur. Do we have any of the speakers from Africa? Dr. Norberto, are you back online?
Hello? Hi, John Blank. I see your message. You say that I'm now good to go? Okay, perfect. Okay, good afternoon, everyone from Mozambique. I'll be presenting about lessons from iReady Mozambique. Let me see if yeah, message. Okay, that's fine. So my name is Norberto Banze. I am from Mozambique, and I'm the executive director of Digital and Health. Digital and Health, it's a Mozambican company working with digital and health technologies. We focus on innovation and seeking to bring systematically digital solutions through a human-centered design process. So in this lessons from iReady Mozambique, I will be presenting about how it was implemented and our experience with the Ministry of Health and all other partners involved in the project. So the Red Plus project aims to build resilience and empowerment to young people. Red Plus is led by Frontline Aids, implemented in 4 countries, including Mozambique, since 2016. The Red Plus has the goal to increase access to holistic care and support for adolescents and young people living with providing not only sexual and reproductive health rights, but also mental health in order to foster resilience. Community adolescent treatment supporters, which we called CATs, young people, which are young people aged 17 to 23 living with HIV, they play a vital role in this project. During home visits, and they provide information, counseling, and support to their peers living with HIV. So the Red Plus project is led by the Regional Psychosocial Support Initiative, REPSI, here in Mozambique. And the project IRED aimed to create information and communication technology tool to provide access to information on sexual and reproductive health and rights, peace support, and adherence to HIV treatment for adolescent and young people here in Mozambique. In the IRED project, there was a partnership with the SPIDER Center, which supports the digitalization of international development. This was done to integrate an information communication and technology component to IRED Plus, and was implemented in 2018 and 2019. So adapting the programming, initially, the idea was to develop an online platform of SRHR material that young people, supporters, could access to assist them in their work. But needs assessment showed that number of existing online resources already provided such information. The project partners agreed later on to develop an interactive health map showing young people where they could go to access health services and commodities. So this led us to the development of the interactive map. REPS partnered with Digital and Health, and under this partnership, we developed an Android app that was used to capture information about places offering youth-friendly services, this in the cities of Maputo, Beira, and Maputo provinces. This information was collected from MOH and we created files for each province, connecting information about the health corners at schools and health facilities with youth-friendly services. And those files were then uploaded to Google Maps. So we have used the Google Maps for the design and also to upload about the points where we have done services. A representative from the Ministry of Health, actually based on actually based from the Directorate of Health, shared the information about all the health facilities that had specific adolescent and young friend services to use as a checklist against what was already included. So this is the illustrations of the application. From the left, we have the home. Once the user opens the Google Map, it takes the user to this screen where we have an information that talks about the project and why this tool was created, and also a kind of menu will be seen on the second screen, where we have a list of schools with health corners. We also have health facilities with specific service for youth, and also some digital health platforms that have been mapped here, which can be accessed through a mobile phone via USSD and SMS. And in the third screen, we have a point being shown. In this case, is one health facility, is the health facility of Altmaier. And here, user has the possibility to get directions, since he will be using Google Maps. So he will get directions to reach a certain point, and with the options also to have a voice guided instruction on how to reach to this point. And once they select the health facility, they will have information about the top services offered at these health facilities and the time, the open time, at what time they can have access to that services, and also some information about the GPS. This map was then shared, once finalized, was shared via Facebook, Instagram, and WhatsApp. And so we have created, we've created a post, and then we boosted the post, targeting specially the target of the project, which are youth. And then we also shared the link to the application using WhatsApp groups. This was disseminated by project partners, reps and frontline, and also the community adolescent and treatment supporters. Since they were already involved since the beginning, they had also this opportunity to give feedback and also elements that needed to be improved. And also they shared the health map with their friends and the ones that they normally work with at the community. So this map is available on Google Maps. We have a specific link, and during this work, we also created an administrator guide so that the map can be updated easily without our intervention, so that the partners can easily, in case they want to add one or two or even more points, they can easily do it. So at the end of July 2019, there were 1,210 maps views at the end of July. So lessons learned and next steps. We learned that programming should be adapted. This ensures the success of iReady Plus, because initially the idea was not, but a different digital health platform. But since we got feedback from local partners and interviews that we had with some partners and NGOs that are already working in various areas of health, so this was key. We had also the feedback of users, and they gave us a very good feedback as they were using the health map. And reps will seek regular feedback from CATs as they use the interactive map in their day-to-day work with young people, and use the feedback to update the map's functionalities, making it more relevant and interesting to young people. Project partners will look into partnering with in-country NGOs for broader dissemination of the interactive health map. We have some NGOs that have SMS platforms, and others that their intervention is more on social media. So I think this would be a good way to disseminate the map, and by having this partnership, they would take the link and incorporate on their platforms so that more people could be reached and benefit from this tool. The Ministry of Health approval, it gave partners confidence because we had some representatives from Maputo, others from Beira, and they were involved right from the beginning. They were checking the data that we had there, and they felt that this was really something that was going to help a lot the young people. So for more information, we have here the links that can be, and to have also a clear idea of what actually the map looks like, and the case study that was written about this project. So it's solved. Thank you so much.
Do we have Miss Claudia back online? She's not back online. Okay. Okay. So then let's move on. So we have a few more questions. I mean, one was regarding the policy bottlenecks in digital health. Maybe I can ask this to Professor Anuraj. Have you, I mean, in doing your work, I mean, have you ever faced any policy bottlenecks from the government, and what were the strategies to kind of overcome it or address it?
Yeah, there have certainly been feedback. Yeah, so there certainly have been some policy issues, some policy bottlenecks. I would say the three most serious ones that needed to be addressed were, first of all, the issues around the data confidentiality and the sovereignty of the data. So the policies around that, data needs to actually reside in the country itself. At least that's here in Indonesia. I think India has laws around that as well. And of course, the issues around the confidentiality, that in fact, are these data in these digital systems, is it really secure or not? That's a really big issue. And then I would say the other really issue has been the human resource laws and guidelines governing frontline worker performance, frontline health worker performance. And these have quite a lot of policies, I would say, that actually don't encourage excellence in performance. And so the way we have dealt with all of these issues is essentially, like the most recent one about the last one about the human resources, working very closely with local government officials, sharing information, and having them develop specific guidelines that are issued by the governor or the district health officer. and just outlining what sort of expectations are there for frontline workers, and that the evaluations received through the frontline digital health system are considered part and parcel of the human resource staff performance. So I would say that's that. And then the issues of the data sovereignty and confidentiality are really, it's again just going through the tests and showing people really what, how the work is in compliance with those. So yeah, those would be my initial comments on that. Very good question.
I would want to also comment.
Yes, Dr. Johnblack, were you saying something?
Yeah, there was a lot of feedback, so I had to mute myself, but I think now it's fine. Yeah, so thanks, Anuraj, for the comment on policy. And I think, yeah, Edna asked this question, and I wanted to give a bit of a concrete example from the Ugandan experience. So the government of Uganda just recently, I think a year ago, passed a data protection law. And I think that came during the wave of GDPR. And first of all, what this shows that initially there was no legal framework to guide this kind of thing. And it means that when you would implement digital health solutions, which are basically information systems, you didn't really have a legal framework under which you are working. So in healthcare, we have always been governed by good clinical practice, and good clinical practice guidelines about confidentiality and privacy of patients, and that has been okay. But normally these they're very subjective. You can interpret them depending on where you are, and usually this lies within the realm of the institutional review board. So the IRBs will review your project, and then they will decide, well, maybe this doesn't fit. One of the common things that happens in clinical research when it comes to data and confidentiality is that typically you want to keep identifying information out of the clinical research information, but that means that then you lose a lot of things that come with digital health synergies. So, for instance, if you would collect data in a register, you want interoperability. So you want to be able to give a unique identifier, and you want to be able to use it in another healthcare setting. Normally, clinical research doesn't traverse institutions. It will be in one setting. So if we're doing a study at the Uganda Cancer Institute, we first of all be not allowed to collect identifying information and have it shared. And if we're not able to share it, if people would use this data, for instance, in our project right now, we have people coming in from HIV clinics, and they are referred to us for cervical cancer screening, which is a very good thing, because then people are in care and they can be referred. So we have a bit of linkage, which is a synergy. But then we cannot have their patient information coming in from the HIV setting coming to us in cancer care, because these are disparate healthcare environments. And most of these projects come in as research projects. And in clinical research, you have this privacy confidentiality issue. So that is one of the issues that usually come in when you have projects. And if you bring them in as implementation, then you have to first finish the research part and get evidence. And then you say, this has now been endorsed by the ministry or by the institution where we're working, and we can pick all the information as we would pick it if we would do things on paper. So that's one of the policy sort of how things happen normally. But going back to the data protection law in Uganda, for instance, there has been an issue of cloud computing, which is becoming increasingly attractive because it solves a lot of infrastructure issues. But for instance, the law in Uganda prohibits putting patient information in the cloud unless the cloud is hosted in Uganda, or if the cloud provider can assure us that they will have the protection and privacy levels that we need. Now, normally when you have something like that, the default position will be, well, we're not going to go into the assurance. We are going to just avoid the cloud, to begin with, because if they give you two options, you can keep patient information in the cloud only if you can assure that they will safeguard the information. The alternative is just keep the information on site. And because it takes a lot of effort for you to figure out if the cloud provider can do the data protection that they need, that you need, or that the government needs, and the risks involved in that, then most times people will say, well, we're going to try and set up a server room here, and we might have issues with cooling it and human resource to maintain it and the technical support, but the law prohibits us from using other alternatives that are available. So that is an issue. And then, of course, the issue of having interoperable systems means that you cannot reuse the data. And interoperability is a policy issue. If you don't have a national identifier, for instance, you're not going to have systems that are interoperable. But I would say that increasingly, some of these things are getting solved, and they are solved sometimes from a different motive. So, for instance, we are getting national identifiers or national IDs in Uganda from a political reason. So, for allowing registration for elections, for instance. But now we can ride on this and say, well, we can actually use the national identifiers for healthcare. And if we can use the national identifiers for healthcare, we can make sure that every patient that goes into hospital uses the same ID, and then we can have interoperability of systems because we can identify people and track them from HIV services, from maternal health, from cancer care. But we need to have government agencies working together and reusing databases like these, like national identification databases, to allow interoperability. So it's really a policy issue. I hope that gives a bit of perspective from the Ugandan setting.
Any questions from anyone for anyone else? Thank you so much. We actually have, another speaker from Bangladesh was supposed to join, who actually basically is in charge of our DHIS2 system and essentially in charge of all data security, data integrity issues in Bangladesh. He will possibly join us in the next webinar. So he was not able to join today due to some traffic issues, but he will definitely join us in the next webinar. So we'll have some perspectives on the data security issues that we are handling from Bangladesh. Possibly for during the next webinar, and we'll also in this webinar we will post some documents on that as part of the resources. So if there are no other questions, I would request Dr. Mustafizur Rahman to kind of give his closing remarks.
Thank you.
Guide us from where we can go from here.
Thank you. Basically, I want to tell only one thing. Problem will be everywhere, and we have to overcome all these problems. We should not get frustrated due to this problem. It is Africa or Asia, it is Indonesia, somewhere else. The digitization started not age of the digitization in Bangladesh is 1 or 2 decades only, and actually last 10 years it happened. So in other areas, history are almost same. So we are working, we are developing, we are improving, we are facing problem. Security of the data is important. Sometimes the national policy is in favor. Sometimes they have some sort of restriction. With all this limitation, we try to overcome, because we need to achieve our goal for the benefit of the people of the country, people of the world. So I think what we are talking about today, maybe our next generation, after 5 years, they will not talk in this way, because they are in the better shape. We have to work, we have to fight, and we have to overcome the problems. So best wishes to everybody. Thank you. Bye.
Thank you so much for those inspiring closing remarks. I welcome you everybody to join the next webinar session, which is supposed to be on October 29th at the same time. And that will be focused more on e-learning solutions in both Africa and in Bangladesh. And hope you all join us in the next webinar session. Thank you so much for your time today.